Let us start this rapid revision of Harrison-based rheumatology. Okay, so in this short video, we'll be discussing about relapsing polychondritis. So we'll start this session with a simple MCQ as which is the most common connective tissue disease that is associated with relapsing polychondritis. The answer is systemic vasculitis. So relapsing polychondritis is an autoimmune disease, okay, which is associated with recurrent episodes of polychondritis. So chondritis means inflammation of cartilage. So there are recurrent episodes of inflammation of cartilage. So the most common cause is going to be systemic vasculitis, which is followed by majority of your systemic autoimmune rheumatic diseases. So this could be a potential MCQ for you people. Okay, right. So while looking into the pathogenesis of relapsing polychondritis, so some unknown trigger. Okay, we do not know exactly the trigger for this disease because majority of the time it is primary or secondary to a connective tissue disease. So that we don't have enough studies about the pathogenesis of these individual diseases. Okay, so the main hypothesis that is postulated is there is inflammation of cartilage. In acute stages, you see a lot of neutrophils, and in patients with recurrent polychondritis, when you biopsy the cartilage, you would find mononuclear cells and plasma cells. Okay, mononuclear cells includes T cells, B cells, and monocytes. Okay, in the form of macrophages. So these are the pathological significance that you see in a cartilage sample. Okay, so what happens because of inflammation? There is loss of proteoglycan in the cartilage. Okay, so this could be seen as a focal or diffuse loss of basophilic stipulin. Usually cartilage stains blue in a eosinophil hematoxylin staining. So when you have loss of basophilic stipulin, which can be either focal or diffuse, it means that the cartilage is undergoing damage. So usually in rheumatoid arthritis, what you see is the erosion start centrally and advances. Okay, it usually the erosions begin in the what do you call as erosion centrally and they spread peripherally. Okay, but what happens in RP is erosions begin in the periphery of the cartilage and they advance towards the center. Okay, and you will have, because of loss of proteoglycan, you will have loss of cartilage, and the loss of cartilage would not be uniform. You would find lacunae of loss of cartilage. Okay, so when the inflammation subsides, it will heal with fibrosis, and you might find foci of calcification or regeneration also. So the predominant T cells that are involved is CD4, it is not CD8, so this could be an MCQ for CD4 T cells being the main hallmarks of relapsing polychondritis. Okay, and on the other hand, you also have B cell activation because T cell dependent B cell activation is possible. So you get autoantibodies to variety of peptides, either collagenous peptides or non-collagenous peptides. So the collagenous peptides include 2, 9 and 11 and the non-collagenous peptide includes matrillin 1. So this could be a potential MCQ against anti-matrillin 1 antibody. Which of the autoantibodies in relapsing polychondritis is associated with the tracheal involvement? The answer is anti-matrillin. About 70% of the patients who have matrillin positivity would have tracheal involvement. But the problem is its sensitivity is very low. It's just present in 13% of all patients with relapsing polychondritis. Okay, so if you have an anti-matrillin 1 positivity, they are at risk of developing tracheal involvement. So what is the consequence of tracheal involvement? We'll discuss shortly. Right. Going to the clinical manifestations of relapsing polychondritis, this is a very important table you must understand. Though it's an old article from which this table has been taken, so this holds good even for the current scenario. Okay. So the most common cartilaginous manifestation or chondral manifestation of relapsing polychondritis is inflammation of your auricles, that is your pinna, external ear cartilage. Okay, so about 90% of the patients would develop auricular chondritis at any point of the time. Okay, which is followed by nasal chondritis, which is followed by laryngotracheal symptoms, and which is followed by ocular inflammation. So these are the symptoms which you should be knowing. So if any patient presents with recurrent episodes of nasal chondritis, auricular chondritis, laryngotracheal bronchitis, and uveitis, so you must suspect relapsing polychondritis. Okay, there are even other rare manifestations which we will be discussing in the subsequent slides. The most common chondral manifestation is auricular chondritis. The most common non-chondral manifestation is arthritis. Okay, so this you must be understanding. Hmm? Right. Constitutional symptoms are present in any of your diseases, be it rheumatoid, lupus, Sjogren's, systemic sclerosis, anything like that. So even patients with RP can have fever, fatigue, weight loss, and other these symptoms. Okay. Apart from this, we'll go one by one. So there are a lot of MCQs. So this could be a picture MCQ for you to diagnose relapsing polychondritis. So this is a reddish or violaceous hue of the cartilage, inflamed cartilage. The skin over the cartilage is stretched and shiny. But see here, characteristically, there is a sparring of your pinna. So this is very characteristic of relapsing polychondritis. So when the patient heals with steroids, your pinna changes over from this phase to this phase. Okay, with recurrent episodes of inflammation of the cartilage, you would develop a flabby or a droopy ear. Okay, so most common symptom is auricular chondritis. This is an MCQ. So it can affect one ear or both ears. It can occur sequentially or simultaneously. Okay, so this is your external ear, and through into the external ear you have the external auditory meatus. As you know, the cartilage of the pinna would extend into the external auditory meatus also. So if that cartilage is involved, you would have external auditory meatus occlusion. So thereby patients can have a conductive deafness. Okay, and there is one more point we should remember, that the eustachian tube is also a cartilage. So when that cartilage undergoes inflammation, you will have a eustachian tube block, which would cause an otitis media with effusion because of negative pressure accumulation within the ear, which would again be a cause for a conductive deafness. Okay, so these are all the cartilaginous manifestations that are causing conductive deafness. But if at all you have a vasculitis of the internal auditory artery branch or its cochlear branch, okay, the cochlea would lose its blood supply and there would be problem with hearing and balance. So patient would be having hearing loss, vertigo, ataxia, nausea, vomiting, all because of your vestibular system dysfunction. So either the hearing system is affected, either the or the vestibular system is affected. Okay, so vertigo is almost always accompanied by hearing loss because it is vasculitis of the cochlea. So both vestibular and your hearing system would be affected. So patients would be having symptoms of either. Okay, but the most common presentation is going to be just auricular chondritis, right? Next we move on to nasal features. So again you have inflammation of your nasal cartilage. Sometimes you get to see an inflamed nose with inflamed cartilage seen through the anterior nares, but majority of the time you don't see any inflammation very prominent. You just have symptoms like nasal stuffiness, rhinorrhea, and epistaxis. Sometimes the nose would be red and swollen, as I said you, and that will in turn lead into a saddle deformity. And sometimes we would not see a red and swollen nose. Straight away you would find a insidiously observing deformity. So the two close differentials of your saddle nose deformity is one, Hansen's disease, and two, vaginous granulomatosis. So when I talk about vaginous granulomatosis is having mucosal involvement. Okay, when you do a mucosal biopsy, you might find a necrotizing granuloma. Here the mucosa is not involved, but the cartilage is involved. Okay, in syphilis also you can have a saddle nose deformity where the bone is involved, whereas in vaginous granulomatosis again the cartilage and the mucosa is involved. And in recurrent auricular chondritis, the cartilage is primarily involved. Okay, so this is how we differentiate. And majority of the patients who are having the saddle deformity and nasal chondritis would also have the other features, like this lady is having some ocular features like suggestive of relapsing polychondritis. And remember, this is common in the young female. So you could see we studied the nose of the patient. So just to give you a pictorial memory that nasal chondritis is common in young females. So this you should understand. Okay, next going on to your articular features. So joint manifestations. Okay, so 1/3 of the patients would be having joint manifestations. It can well anticipate RP. So initially you would be treating them as undifferentiated polyarthritis, RF anti-CCP negative. We do not know what the patient would evolve into. And all of a sudden patient develops a auricular chondritis. So this could be a presentation. But what is specific about the arthritis of relapsing polychondritis is it is not like RA. It would have an asymmetric manifestation. oligoarthritis or polyarthritis. Okay, so either small and large joints both can be involved. And when the cartilage of the chest wall is involved, you will have a pectus excavatum, which is otherwise called as a flail anterior chest because of the cartilage of the chest getting involved. Okay, and majority of the time the question would be asked, it would be given an option that arthritis in IBD, that is the type 1 arthritis. We'll discuss about arthritis in another, intrapathic arthritis in another video. They are usually correlating with the bowel activity, but here in RP, the attacks are not correlating with your RP disease activity. And when you look at the synovial fluid, it would be just like a non-inflammatory synovial fluid analysis. However, patients do respond to low-dose steroids and methotrexate if they have a significant synovitis. I told you the symptoms of arthritis could be the feature of rheumatoid arthritis or lupus also. So RP does not come alone, please remember. So RP can be either primary or secondary. So in those secondary cases, steroids and immunosuppression, immunomodulation would help in decreasing the synovitis. So going to the eye, you can have any layer of the eye that can get involved. So right from the periorbital region, which will have a periorbital edema, they may have a conjunctivitis, episcleritis, scleritis, keratitis, uveitis, okay, anything. Proptosis because of muscle inflammation and proptosing of the eye, extraocular muscle palsies, inside the eye, retinal vasculitis and retinal vein occlusion. So they can have any of the presentation of the eye. So always keep your mind open because see here, ophthalmological manifestations are the presenting manifestations in about 18% of the patients. So these patients might develop auricular chondritis in up to 90% of the time. So that is what you should understand. So recurrent uveitis, always watch for relapsing polychondritis. Recurrent keratitis, recurrent scleritis, recurrent episcleritis, always watch for relapsing polychondritis. I have one of my patients who is having recurrent episodes of uveitis. Okay, shockingly his her anti-CCP is positive, and it has been repeated many times and many times it is consistently positive. But she has not developed any features of inflammatory arthritis or other things suggestive of rheumatoid. So probably she might evolve into a relapsing polychondritis. Who knows? God only knows. Okay, she's doing well on methotrexate without any more recurrent episodes of uveitis. Right. Now moving on to the next manifestation, which is your pulmonary manifestation. So pulmonary manifestation is going to be the life-threatening manifestation of relapsing polychondritis. See in this CT, you are able to see a saddle nose deformity. Okay, and here you are able to see the glottis undergoing edema, and edema is also seen in the subglottic region. Okay, so this edema is because of inflammation of your vocal cord and the supporting cartilaginous system. Okay, and here what you see is the tracheobronchial junction bifurcation, where you could see a concentric thickening of your tracheal wall, which is made up of cartilage. And see here, in trachea, the anterior two-third is thickened and the posterior one-third is not thickened. But as you know, only the anterior two-third of the tracheobronchial regions would be made up of cartilage, and the posterior one-third would be made up of only mucosa. So that is very, very clearly explained based on this picture also. So you will get a thickening of your tracheobronchial bifurcation. And sometimes when you have a bronchial obstruction, endobronchial obstruction, patients might develop recurrent episodes of obstructive pneumonia. Okay, so the inflammation heals with scarring. Okay, sometimes patients may develop a permanent stricture, so they will have difficulty in both inhalation and exhalation, and sometimes they might have a tracheobronchiomalacia. Okay, so it is, if the tracheobronchiomalacia is above the thoracic cavity, patients would be having difficulty in inspiration, and if the tracheobronchiomalacia is below into the thoracic cavity, the patients would be having difficulty in expiration, and these would be reflected in your pulmonary function test. So not as a part of rheumatology, so these charts and curves could be given as spotters for you to answer the various types of obstructions causing difference in pulmonary function. I'll show you the pictures shortly. Cardiac features, yes, it is because again of the inflammation of the cartilage protein in your aorta, the roots. Okay, because of that there will be a root dilatation and patients will be having aortic regurgitation. And apart from this, patients can have pericarditis, myocarditis, Coronary vasculitis, conduction abnormalities, aneurysms. Aneurysms are really dangerous. And sometimes the patients would not have any features of relapsing polychondritis. They would just present with aneurysms and later they might develop relapsing polychondritis. So, relapsing polychondritis is a variable vessel vasculitis. So, by affecting the large vessels, it can cause aortic aneurysms. By affecting the medium vessels, it can cause aneurysms or inflammation of your coronary arteries, the heart, gut mesenteric vessels, hepatic vessels, renal vessels, and the vessels supplying the nerves. So they can also present like a patient who is coming with a polyarteritis nodosa. Correct. The patient would be having fever, weight loss, abdominal pain, hematuria, renal dysfunction with microaneurysms, and mononeuritis multiplex. And the patient would have had a history of recurrent auricular or nasal chondritis, and sometimes CT might be showing asymptomatic tracheal wall thickening. So you have to correlate features. You have to look for RP in every case of medium vessel vasculitis. And small vessel vasculitis is common in the form of purpura, which would be showing on histopathology as a leukocytoclastic vasculitis. Right. Renal involvement, the most common involvement is mesangial expansion, okay, followed by segmental necrotizing glomerulonephritis, and some patients can have tubulointerstitial disease and IgA nephropathy. Okay, skin features, purpura is the most common one, and apart from that, patients can have erythema nodosum, erythema multiforme. Because the cartilage is getting involved, they can have some allergic manifestations like angioedema and urticaria. As a part of medium vessel vasculitis, they might also develop livedo reticularis, and inflammation of the subcutaneous skin subcutaneous fat would cause panniculitis. Right. In the labs, what you see a mild leukocytosis, normocytic normochromic anemia, eosinophilia, acute phase reactants being elevated. Your autoantibodies may or may not be positive. If at all they are positive and you don't have a CTD associated with it, they are usually of low titers. But if they are high, you should always look for a secondary RP rather than a primary RP. Okay, so imaging, you need to go for a CT chest. Okay, any RP patient, please do a screening CT chest to see if the patient is having a tracheal wall thickening, and get an MRI done if needed. Okay, angiogram for vasculitis purposes, PFT. So this is your normal flow volume loop. So this is your inspiratory curve and this is your expiratory curve. And normally you have the patient starts having a tidal breathing, so you would see some marks over here in a usual PFT machine. And what the patient would do is take a deep inspiration and a forceful expiration. So this is how the flow volume loop is completed. Okay, as I told you, when the patient has tracheomalacia in the extrathoracic compartment, okay, what do you get? You will have difficulty in inspiration, but the expiration would be normal. So what happens is a squaring of your inspiratory loop. Okay, so this obstruction is variable because it is only a malacia, it is not a stricture. Okay, but here, if the tracheomalacia is occurring in the intrathoracic cavity, okay, now what will happen? Patient's inspiration would be normal because the extrathoracic compartment is unaffected, but the intrathoracic compartment is affected, so there will be a squaring in the expiratory loop. Okay, what if the patient has a fixed, the patient has gone for a tracheal stricture? So in that case, the boxing will be both on inspiration and expiration. So for the cardiac assessment, you can do a ECG and 2D echo. So the diagnosis is based on the McAdams criteria and Damiani-Levin criteria. So Damiani-Levin criteria is for the diagnosis of DASH. This could be an MCQ. McAdams criteria is a diagnosis of which disease? RP. So if you don't know this name, you would obviously miss this MCQ. So please remember this. So the criteria is including the common features as you see here: chondritis, arthritis, nasal chondritis, ocular inflammation, respiratory tract chondritis, and cochlear or vestibular dysfunction or both. Okay, so this is what you should know. Don't forget McAdams and Damiani, right? So that you have a lot of treatment options for relapsing polychondritis. Steroids are the first line of agent. Okay, if the patient is not like on tapering steroids, the patient is having recurrent episodes, you add dapsone, which is the drug of choice for relapsing polychondritis. So steroid sparing agent of choice for relapsing polychondritis, the answer is dapsone. Okay, in cases where dapsone is contraindicated or the patient is not responding to dapsone, you can go for other immunosuppressions. So as rheumatologists, we prefer to use methotrexate more when compared to dapsone. Okay, so other options like azathioprine, cyclosporin, cyclophosphamide can be used. In refractory uveitis, you might even need to administer intraocular steroids. Anti-TNF, tocilizumab and rituximab are indicated in refractory cases. If the patient develops a subglottic stenosis with stridor, you need to go for a tracheostomy. Strictures can be managed by stent. And if the patient develops regurgitation, you need to go for repair. And if the patient's aneurysms are symptomatic, you need to go for repair. Okay, so with this, we end the topic on relapsing polychondritis. It's bye for now. Thank you.